Hello and welcome to the Business Talk podcast. I'm your host Deepak. I'm delighted to welcome Dr. Susan Feng Lu, Professor of Operations Management and Statistics and the Alan Hudson Chair in Health Policy at the Rotman School of Management, University of Toronto, as our distinguished guest on today's episode. Dr. Susan received her PhD from the Kellogg School of Management at Northwestern University and is recognized as a leading scholar at the nexus of health economics, operations, and analytics. Professor Lu's research investigates the operational foundations of healthcare delivery with a focus on how public policy and technological innovation shape the efficiency, quality, and equity of healthcare systems. Her expertise spans areas including health technology, nursing home operations, and cardiac care delivery. She leverages empirical methods and machine learning to tackle critical challenges in healthcare operations. Her work has been published in premier journals such as Management Science, Manufacturing and Service Operations Management, Production and Operations Management, Review of Economics and Statistics, Journal of Health Economics, and Information Systems Research, as well as high-profile interdisciplinary outlets like Science and Nature Scientific Reports. Professor Susan's research has received numerous awards, major research grants, and widespread media coverage, including features in Barron's, Nature, Freakonomics, and Vox. She serves the academic community as an associate editor for Management Science, Manufacturing and Service Operations Management, and Production and Operations Management Society, and currently leads as the president of Chinese Economics Society. In addition to her academic contributions, she has testified before the United States Senate and has mentored entrepreneurs as an economics mentor for the Creative Destruction Lab. In this episode, Professor Susan will share valuable insights from her research, leveraging machine learning for healthcare operations, enhancing efficiency and quality. Kicking off this exciting conversation, let's warmly welcome Professor Susan Lu to the show. It's a real privilege to welcome you, Professor Susan. Thank you for joining us.
Thank you. Uh, Thank you for inviting me to attend this Business Talk podcast. Yeah.
Thank you. Professor, to start, could you share perspective on the biggest operational challenges in healthcare today that machine learning is particularly well suited to address?
I see three major operational challenges. First is the issue of trust. Patients and physicians alike often have a natural aversion to AI and may hesitate to rely on AI recommendations. Hence, building trust in AI systems so that both patients and providers are comfortable using them is critical. Second, there is a data quality and integration challenge. Well, we have vast amounts of healthcare data. Much of it is messy, incomplete, or recorded inaccurately. Clean, well-linked data is essential for reliable machine learning. Additionally, patient data is often siloed across different institutions, and privacy regulations make it difficult to link these records for comprehensive analysis. The third challenge is embedding AI tools into clinical workflows. Even when an AI application works well in theory, integrating it into a hospital's operational systems is a long and difficult process. In my experience, it often takes 1 to 2 years to fully incorporate an AI product into a healthcare setting. And even then, continuous learning and maintenance remain a challenge.
Very insightful. Professor, how has the application of machine learning in healthcare operations evolved over the past decade? And what are the some breakthrough you have found most exciting?
Mm, Well, over the past 15 years, we have seen three key phases of evolution in healthcare AI. The first phase is from 2010 to 2015. We observed the emergence of basic predictive models, used to predict things like hospital readmissions or length of stay. These were largely built on traditional methods like logistic regression, decision trees, and random forest. Between 2016 to 2020, models became more sophisticated. Researchers began addressing healthcare-specific issues like data imbalance and started developing ensemble models and early real-time systems. And the third phase, actually starting from 2020, things have developed dramatically. So we now have the streaming data capabilities, real-time anomaly detection, and powerful tools like natural language processing, large language models, and generative AI. These actually allow us to analyze unstructured clinical notes, detect changes in patient status on the fly, and even simulate diagnostic reasoning. Regarding the breakthroughs, I think there are two breakthroughs I find particularly exciting. The first is the AI-assisted prescription systems, which read drug labels and doctor notes to detect dosage errors and harmful drug interactions. These systems can automatically alert doctors to potential issues, greatly reducing the risk of medication errors. And the second one that excited me is the AI diagnostic assistants that often offer the second opinions. For example, if a doctor diagnoses disease, say A, then the AI may respond, say, okay, there is a 50% of disease A, but also, a 30% chance of disease B and a 20% of disease C. This kind of feedback actually encourages doctors to double check their reasoning and consider alternative diagnosis. So these are the two, I think, breakthroughs I find particularly exciting.
Dr. Susan, in your research, how do you approach balancing the twin goals of enhancing operational efficiency and maintaining or even improving the quality of patient care?
I think that's an excellent question, and one that sets the healthcare analytics apart from the traditional business fields like finance and or marketing. So in most industries, the goal for analytics is clear. That is to maximize profit and minimize cost. But in healthcare, quality of care must always be the primary objective. When I conduct research, my guiding principle is always to improve patient outcomes. I believe that if we deliver high quality care, efficiency and cost savings will follow. That's why my work focuses on identifying ways to improve quality using available resources, while also streamlining processes and reducing waste through better operations management.
Professor, could you walk us through a case study where machine learning significantly improved outcomes in healthcare setting, such as nursing home, cardiac care, or hospital management?
Absolutely. I would love to share a case with you. This case really sticks with me because it was one of the most meaningful moments in my research career. So it happened in 2015. A close friend of mine, who is also a world-known cardiologist, called me in distress. He had just treated a patient who had suffered a heart attack and was also paralyzed. Okay, so For these patients, for those heart attack patients or AMI patients, there are typically two treatment options. One is PCI, which is a less invasive procedure. The other is CABG, an open heart surgery. And the entire medical literature has a long and inconclusive debate on the effectiveness of these two treatment options. So after checking the patient conditions and status, my friend strongly advocated for PCI in this case. But another doctor, who happened to be the friend of the patient's family, convinced them to opt for CABG. Sadly, the patient was sent to a nursing home after undergoing the CABG and never made it back home. There was no existing literature at that time to guide decisions for patients with both heart attack and paraplegia. So my friend asked me if I could help find some evidence. So I say, okay, let me give it a try. I pulled together about many years of US hospital data and found only 1,400 relevant cases. What does this mean? This means among all the AMI patients, only 0.3% have such rare conditions. That scarcity explained the lack of clinical guidelines in the literature, because most physicians in their entire career, never encounter this combination of conditions, and they don't know how to treat them. And we used the standard statistical and machine learning methods to analyze the data. The results were clear. AMI patients with paraplegia who underwent CABG had about 12.7 times higher mortality rate than those who received PCI. This led us to publish our findings in one of the top medical journals, but more importantly, this helped us to save lives, because 3 years later, my friend encountered another similar patient. This time, he confidently showed the family our study and performed PCI, and the patient was discharged home 3 days later with his quality of life intact. So this experience actually showed me the power of using big data to fill knowledge gaps about treatments for rare conditions and save lives.
Healthcare data can be messy, incomplete, and complex. How do you navigate these data challenges when developing machine learning models for healthcare operations?
Well, this is another excellent question. One of the biggest challenges in healthcare machine learning is data quality. Many of my colleagues actually have spent tons of time to develop techniques to handle this. But if I'm honest, I have found that no shortcut replaces hard work. In nearly every project I have done, about 70% of my time is spent just understanding and cleaning the data, checking for missing values, resolving inconsistencies, and interpreting ambiguous entries. Only 30% is spent modeling and writing. Healthcare data are often collected in busy clinical environments, not for research purposes. So they are filled with noise. Before applying any machine learning algorithm, it is absolutely essential to gain domain knowledge and make careful judgments to ensure the dataset is accurate and meaningful. Otherwise, we may risk producing misleading or even harmful algorithms.
There is often concern about algorithmic bias in healthcare. How do you ensure that machine learning tools promote equity and do not exacerbate existing disparities in healthcare access or outcomes?
Mm-hmm. This is another deeply important question. So algorithmic bias is a major concern in AI, especially in sensitive domains like healthcare. The truth is, bias is embedded in the data itself, because data are generated by people, and people carry their own biases. Whether it's in diagnosis patterns, treatment preferences, or access to care, historical inequalities get baked into the dataset. I don't have a perfect solution for this. Researchers have proposed fairness-aware models, subgroup analysis, and regular auditing. But at the end of the day, I believe it's our responsibility as data scientists to stay vigilant and transparent about where bias may exist. We must also collaborate with domain experts and policymakers to ensure that these tools are used responsibly.
So, Susan, public policy plays a big role in healthcare. How do regulatory framework support or hinder the use of machine learning in operational decision making across healthcare systems?
I do think that public policy is essential in shaping how machine learning is applied in healthcare. It's truly a double-edged sword. Let me give you an example. For example, the regulation on patient privacy. On one hand, regulations such as HIP in the US or FIP in Canada play a crucial role in safeguarding patient privacy and ensuring ethical data practices. These protections are fundamentally important to building public trust in AI and data-driven healthcare. On the other hand, these same privacy regulations can pose significant barriers to data access and integration, because healthcare data is often siloed across institutions, and patient identifiers are encrypted. Linking records across different datasets becomes technically and legally complex. This lack of interoperability limits our ability to develop machine learning models that capture the full patient journey. For example, programs like the Meaningful Use, introduced in 2009 in US, have encouraged hospitals, physicians, pharmacies to exchange healthcare information and improve data sharing. It is very successful. But in Canada, to the best of my knowledge, interoperability at this stage remains limited. The result is fragmented data that constrains both clinical insight and algorithmic performance. Ultimately, policymakers needed to strike a careful balance, protecting patient rights while enabling responsible data integration and innovation. Without this balance, we risk underutilizing machine learning's potential to improve healthcare delivery and outcomes.
Dr. Susan, where do you see the biggest opportunities for interdisciplinary collaboration between healthcare professionals, data scientists, and policymakers to maximize the impact of machine learning?
I do believe that interdisciplinary collaboration is essential for the future of AI and healthcare analytics. In fact, I believe it's the most important ingredient for meaningful progress in this space. There are lots of opportunities in this domain. One promising area is in helping physicians treat rare conditions. By aggregating large-scale data across institutions, we can identify effective treatment plans for patient populations, too small for clinicians to gain experience with individuals. This kind of support is only possible through close collaboration between clinicians, data scientists, and policymakers.
Looking ahead, what emerging machine learning techniques or innovations do you believe will transform healthcare operations over the next 5 to 10 years?
Generative AI will be a transformative force in healthcare. Right now, when a patient visits a doctor, the interaction involves two parties. But in the future, generative AI could become a third participant, actively involved in the conversation, documentation, diagnosis, and even treatment planning. This actually raises many important questions here. Should generative AI be integrated into clinical encounters? How can it support both patients and physicians in a way that is accepted and trusted? How will its involvement change the dynamics of care delivery? Unlike past innovations like the computer or the internet, which enhanced human capability by providing tools, generative AI is unique in that it can start to assume elements of human decision-making. That shift forces us to think critically about which decisions can be safely delegated to machines and which must remain with human clinicians. Understanding this boundary will be critical in the next 5 to 10 years.
Dr. Susan, my last question. For healthcare leaders and practitioners eager to adopt machine learning solutions or AI, what key advice would you offer to ensure that these technologies are implemented thoughtfully and effectively?
So here I have 3 main pieces of advice. The first one, start with pilots. Before fully adopting any machine learning solution, please run a pilot project, for example, an A/B test, to rigorously evaluate its impact on patient outcomes. Because not every AI product is good. Like all models, they are prone to type 1 and type 2 errors. A careful assessment is essential before integrating any system into the current clinical workflows. The second advice is to focus on integration. If a tool proves effective, then the next step is figuring out how to embed it into the existing healthcare delivery system. Technology alone doesn't solve problems. It must be implemented thoughtfully. This might require changes in organizational structure, training programs, or even the culture of how decisions are made. And the third advice is to commit to continuous learning. Machine learning models are not static. They may perform well this year, but as patient populations and practice environments change, their accuracy level could be changed or be degraded. So leaders must invest in systems that support ongoing monitoring and retaining of AI tools. Periodic reviews and updates are necessary to maintain performance over time. So I would say healthcare leaders and practitioners must be proactive, thoughtful, and informed. AI is powerful, but only when used wisely, or supported by strong collaboration and anchored in a deep understanding of both technology and clinical care. Thank you. That's all.
Thank you, Dr. Suzanne Lu, for joining us today and for sharing illuminating insights drawn from a remarkable body of research. Your work at the intersection of healthcare operations, public policy, and machine learning provides both a rigorous and deeply human perspective on the challenges and opportunities facing healthcare systems today. On behalf of our audience, I extend a heartfelt thanks to you, Professor Lu, for an engaging and thought-provoking conversation. We look forward to following your continued contribution to this critical field. Thank you so much.
Thank you.